We will continue our discussion on the acute cardiovascular response to exercise, and we've been discussing how the cardiovascular system is able to increase the volume of oxygen coming into the body during this acute bout of exercise. So VO2 stands for volume of oxygen. And as we exercise, we increase the volume of oxygen our body takes up. And that is because if you go way down at the end of the chain, in the skeletal muscle, there are mitochondria that require oxygen for aerobic respiration in order to make the ATP that fuels the contractile apparatus of the muscle. So all of these systems, our lung, our heart, our blood vessels, are all working together to deliver this oxygen so the mitochondria within the muscle cell can make sufficient amount of ATP to fuel the machine that is our muscles. So we were breaking down this volume of oxygen in the first half of this lecture and discussing the components of the cardiovascular system that contribute to changes in the volume of oxygen. And we left off on this slide. We said the volume of oxygen brought into the system and utilized by the body is dependent on the oxygen extraction. How well can the skeletal muscle get the oxygen out of the blood and deliver it to the mitochondria? In other words, the AVO2 difference. And it's also dependent on the cardiac output. How efficient is our pump at dispersing that blood throughout the body? Because if you get the oxygen in, you have to be able to deliver it. So cardiac output is heart rate times stroke volume. And at this point, we have discussed those elements that control and regulate heart rate, how heart rate can go up during exercise, and the impact on cardiac output. Our next piece we have to talk about is the stroke volume, and how does that change during exercise, and what is its role in increasing the volume of oxygen brought into the body, or the VO2. So during an acute bout of exercise, this graph is showing percent maximal work on the x-axis. So as you head to the right, we're increasing exercise intensity up into a VO2 max here at 100%. And on the y, we have stroke volume. And what you'll see is that in response to exercise, there is an increase in stroke volume, but it really only increases until about 40% of your VO2 max, and then it completely plateaus, where there's no further increase in stroke volume. So let's first just discuss how we increase stroke volume in the first place. So increasing stroke volume means that you have more blood leaving the heart per beat. And during exercise, it would be advantageous to cardiac output if we can get more blood out per beat. So how do we accomplish this? The first, we have to remember the relationship between stroke volume and afterload. Afterload is the resistance the heart has to overcome to eject the blood. Remember that between the left ventricle and the aorta, we have the aortic valve. And the aortic valve is going to be closed by the back pressure of the peripheral vascular system. And the only way to open it is to have the left ventricle create a higher driving pressure than aortic pressure. So a lot of times people use afterload and aortic pressure synonymously because that's the gateway between the two, the pressure that the left ventricle has to overcome. But the afterload is really driven by the total peripheral resistance of the system. So if you cause massive vasoconstriction in the body, that would raise afterload. And if you cause massive vasodilation throughout the vascular resistance vessels of the peripheral circulation, you would drop afterload. So during exercise, we see this dramatic effect on the blood vessels. I should say during dynamic rhythmic activity, especially when you're using large muscle groups, you see a huge vasodilation, right? This graph shows that during exercise, we basically shunt our blood to our skeletal muscles through the process of vasodilation, right? Again, that vasodilation is driven by the local metabolic byproducts, which is why the larger the muscle group involved, the more of your body involved in the exercise, the greater the effect on this drop in total peripheral resistance. So during exercise, this massive vasodilation would really reduce your overall afterload in the system because there's less resistance that the heart is pumping into because of the vasodilation. So one of the factors that raises stroke volume during exercise is the vasodilation of the peripheral circulation, or the drop in afterload. Next, we want to make sure we have tied in our brains the relationship between preload and stroke volume. Preload is the volume of blood that gets into the ventricles right at the end of diastole. How full is the heart right when it is ready to beat? So how does preload change during acute exercise? Well, the first thing that happens is the sympathetic output causes a vasoconstriction. Now, if that feels wrong to you, because on the previous slide, I was just talking about this massive vasodilation, remember the separation between the central control of blood vessels and the local control. Any sympathetic neuron that's innervating a blood vessel would be leading to vasoconstriction. That is the sympathetic response in a blood vessel. Any blood vessel that is near a metabolically active tissue could override that system, that sympatholysis, and actually cause a vasodilation even in the face of the sympathetic nervous system. But in this case, when we're talking about the vasoconstriction, we're really thinking about the vasoconstriction of the veins. So you'll notice in your notes, it's written as venoconstriction to really drive home the point that we're talking about the veins. So the sympathetic activation causes vasoconstriction globally, which means that the smooth muscle of the veins would contract. Now remember, our venous system is, it stores a lot of blood. It's a highly compliant blood vessel, very stretchy. So when you venoconstrict and you decrease the volume of the veins, that is going to help drive blood back up to the heart. So the venoconstriction will help drive the venous blood back up to the heart. So you actually have a greater total amount of blood in your circulation because less is kind of hanging around in the veins. Ooh. Come back. All right, the next piece is the fact that you are exercising and the skeletal muscle squeezes around the veins. And this is referred to as the skeletal muscle pump. And you can see here the vein is open, blood can travel upwards. As the muscles contract, you see a squeezing of the vein, which would help to push the blood up. And then as the muscle relaxes, it allows a greater amount of blood back in the vein. In fact, when the skeletal muscle pump is really active, it squeezes so much blood out at this point that there's actually like a negative pressure in the vein that helps suck even more blood up, kind of like a vacuum. So as you are rhythmically contracting the muscles around the vein, you are helping to drive and pump that venous blood back up to the heart. This becomes a fundamental principle in many settings in physical therapy. If somebody is not getting their blood pressure up, we try to drive the blood up to the heart by doing some ankle pump to try to facilitate that skeletal muscle pump. So it happens naturally during exercise, and it's one of the factors that helps increase the total amount of blood being returned to the heart. The last one is the respiratory pump. Now this is a very significant pump, and I think it isn't as well understood. So let's just think about what happens during breathing and those large veins that are heading back to the heart, the vena cava, returning all that lower extremity blood. When you take a big breath in, you create a negative pressure in the thorax. That negative pressure is actually going to almost act like a suction. A suction that creates a negative pressure in the vena cava, which actually helps to pull the, increase the volume in the vena cava. And then as you exhale and you contract your abdominal muscles, that helps to squeeze on the walls of the vena cava and pushing the blood up. So on inhalation, this negative pressure sucks the blood up into the vena cava. Exhalation, the increased pressure on the outside squeezes the walls and pushes that blood that you just loaded the vena cava with up into the system. So with this negative and positive pressure back and forth with every inhalation and exhalation, you create this respiratory muscle pump. So we have added to our figure that the drop in afterload helps facilitate a stroke volume. And during exercise, we see an increased venous return. Venoconstriction, skeletal muscle pump, respiratory muscle pump all contribute to more blood being returned to the heart, which means you have a greater end diastolic volume. So we've described how we get more blood in the heart, but how does that increase stroke volume? Well, this gets back to the Frank-Starling law, and the simplest answer to the question, how does increased blood in the heart increase stroke volume? And that's simply because more blood in equals more blood out, right? If you add more liquid to a container, when you dump that container out, you had more liquid to dump out. And it is that, there's a piece of it that is that simple. But if you look at the relationship between stroke volume on the Y and increasing ventricular end diastolic volume on the X, you will see that this is not a linear relationship. In fact, the dotted line in the slide shows you what you would expect to happen to stroke volume if it was based on volume alone. You would think that for every increase in volume, there would be kind of an equal increase in stroke volume. But Frank-Starling shows this curve that has an exaggerated effect on stroke volume, and that is because of the Frank-Starling law. So the Frank-Starling law describes how when you stretch the myocardium, you actually get an increased force of contraction. The stretching of the myocytes stimulates a greater forceful contraction. So the increasing end diastolic volume and creating this stretch actually stimulates an increased contractility. The heart squeezes harder. It's not just about the volume, the force of the contraction also goes up. So when you increase end diastolic volume, you stimulate the contractility of the myocyte, and now you have an increased strength of cardiac contraction. So this is all occurring during exercise. This peripheral vasodilation drops the afterload. These factors that are returning more blood to the heart gives up the heart more volume to play with, stimulates contractility, but there's even more going on because when you are exercising, you have a sympathetic output. So this simple graph of the Frank-Starling law is only showing the relationship between stroke volume and end diastolic volume. If we would add in the fact that we have a sympathetic stimulation, you can see that the activation of the sympathetic nervous system is another way of stimulating contractility because the ventricle is actually innervated by sympathetic nerves, stimulating that contractility. So at the same end diastolic volume, so if we pick a spot, let's say this is where we are, when you have sympathetic stimulation, that will exaggerate this response. And at the exact same end diastolic volume, we see a dramatic increase in stroke volume because you have the added contractility of what the sympathetic nervous system gave you. So we discussed the factors that took your end diastolic volume and increased it with exercise. And now we're adding in the piece that we not only activate Frank-Starling and move along that curve, but we get the added benefit of the sympathetic nervous system. So if we add this in, we have sympathetic activation, which does help contribute to venous return because of the venoconstriction, as well as this effect on the heart to stimulate the contraction. I want to take a quick step out and just have a little farm reminder here, because you guys are going to treat a lot of patients who are on medications that affect their heart. And it's good as we're thinking about this effect on stroke volume to also think about drugs that you might already be aware of that can have a similar effect. So drugs that increase the contractility of the heart are known as inotropes. And there's a whole host of these drugs. Digitalis is a big one. Milrinone is a huge heart failure drug that you'll see. Dopamine, dobutamine, drugs that kind of act like the sympathetic system can stimulate the stroke volume. And it's important to know what drugs your patients are on because it might be having a huge impact on their cardiac response. So I just wanted to drop that little reminder in there so we're not forgetting this farm knowledge and how this can add a whole nother layer of complication to the cardiovascular system. You know, you guys, you learn the cardiovascular system in phys, and here's how it works. Now we're adding basically the greatest challenge to cellular homeostasis, exercise. And in the real world, you're going to also have that added layer of pharmacology, which we'll kind of weave together even more in cardiopulm. But I just want to get you thinking that a lot of the patients that we're going to be measuring their vitals and assessing their cardiovascular response to exercise will also be on pharmacological meds that can be impacting that response. Okay, so on the bottom of your notes, there is a summary of the exercise-induced changes in stroke volume. So you have a place where it all comes together. When we exercise, we have an increased contractility. And that is because of both the sympathetic nervous system as well as the Frank-Starling activation. When we are having an acute bout of exercise, we have an increased venous return, which is contributing to that increased stroke volume. We have the skeletal muscle pump, the respiratory pump, as well as the sympathetic nervous system, all contributing to that increased venous return. And then finally, our stroke volume is further supported by the drop in total peripheral resistance, or the drop in afterload, that makes it easier to get the blood out of the heart. So we know during acute exercise, there's increased heart rate, increased stroke volume, leading to a greater cardiac output. How does this relate back to our patient Joe and why we initially screened him? What were we worried about? Why did we take the time to go through, that algorithm you can see in the background of the slide? We were worried he had an underlying heart disease, right? It's one of the more common diseases in our country. We're worried he could suffer an MI or have a serious heart rhythm disorder. Why are we talking about heart disease when we're in the, section of your notes on acute response to exercise? What is the relationship between those two? Well, exercise is going to increase the work of your heart. What does that mean when we say exercise increases the work of your heart? It's increasing myocardial oxygen consumption, right? So just like skeletal muscles need more oxygen during exercise, this slide here, I've kind of always been saying, we got to get all this oxygen to our muscles because it needs ATP. The heart is a muscle, and it is one of the areas that needs an increased oxygen. So if you are increasing the heart's work to pump this oxygen to all those peripheral muscles, the heart itself also needs more oxygen. If somebody has an underlying heart disease that compromises the ability to deliver enough oxygen, and we add the external stress of exercise, which challenges the heart and makes it work harder, you could potentially find yourself in a situation where you have mismatch between supply and demand, and someone can get into some serious cardiac trouble. That's what we're worried about. This is why we screened Joe, to try to see if he had underlying heart disease, metabolic disease that was undiagnosed before we started to exercise him. That being said, we're going to exercise a lot of people who have underlying heart disease. And at the very beginning, I kind of tried to say that the risk isn't as great as you think if we're safe and we know what we're doing. So let's see if we know the answer to this question. If you want to increase cardiac output, which you do during exercise, because increasing cardiac output will help you deliver oxygen and help you be more successful in your exercise or whatever you're challenging the body to do. But you want to increase cardiac output with the least amount of work on the heart. You would like to increase cardiac output without having too much of an increase in myocardial oxygen demand. Which of your two choices of the cardiac output equation, heart rate or stroke volume, which of these two would be the most beneficial to increase cardiac output with the least amount of myocardial work? So when is the heart using ATP? When is it working? When is it requiring all that oxygen? It's when it's beating, right? When the heart is actually beating, oops, I didn't realize we weren't in play mode. When the heart is actually beating is when it's working, right? All those cross bridges pumping together to make this contraction. This is when you need all the ATP. So if you could fill the heart with a greater volume and actually have it beat less times, you would be able to increase cardiac output with a lower myocardial oxygen demand. So we can keep track of this and see where our patients are with a very simple equation called the rate pressure product. And the rate pressure product estimates the amount of myocardial oxygen consumption. So we mentioned that when the heart is beating is when it's working. So the rate of tension development or the number of cycles per minute is going to impact the amount of oxygen your heart needs to get the job done. The other piece of that goes into the rate pressure product is the systolic blood pressure, because systolic blood pressure represents the amount of pressure the heart created, right? That's when the heart and the blood vessel system are open to each other. So systolic blood pressure really tells you about the amount of tension that was developed in the heart. So they have done studies that show a very high correlation between the rate pressure product, simply taking the heart rate and the systolic blood pressure together, and it highly correlates with myocardial oxygen consumption, which is such a handy thing for clinicians because these are two vital signs that are very easy for us to take and keep track of and monitor how our patients are doing at different levels of myocardial oxygen consumption. The other name for rate pressure product is the double product. So you might have heard that those two terms are synonymous. So we want to keep track of myocardial oxygen consumption, especially in our patients who have underlying heart disease. And the reason this is such a big deal in the heart, if you remember from pathophys, we talked about how the myocardium is a flow-limited system. What that means is at rest, the myocytes are taking out almost all of the oxygen. There's maximal oxygen extraction at rest. So when you increased oxygen demand in the heart, the only way to get more oxygen to a myocyte is to increase blood flow. So if there is anything compromising blood flow, you can quickly get into an imbalance between supply and demand. And as the heart rate increases, you're more and more likely to show that imbalance, because when the heart is beating is when it's working. So if someone is having inappropriately high heart rates, they're at a greater risk for myocardial oxygen imbalances than somebody who's exercising at the same intensity with a lower heart rate. And again, what would that look like? When I say they're having an imbalance, what happens to that patient? They might experience chest pain, tightness, pressure, shortness of breath, palpitations, feeling of indigestion and burning in their chest. Signs of an imbalance, signs of ischemia. It's a really important thing to keep in mind that when those heart rates get higher, the oxygen consumption of the heart goes up. So let's put it all together. We said that when you increase exercise intensity, you increase the oxygen consumption. The piece of this that comes from the heart is the cardiac output. And cardiac output has an extremely sharp rise up into about 40% of VO2 max. And that is because cardiac output is a combination of heart rate and stroke volume. And we know that stroke volume increases up to that 40% as well. And heart rate has a linear relationship between exercise intensity. So the very beginning of that cardiac output is a combination, excuse me, of the increases in heart rate and stroke volume. Once you get past about 40% VO2, the rest of that increase in cardiac output is all coming from heart rate. Clinically, this kind of takeover of heart rate to control cardiac output is largely shown to be close to around about 120 beats per minute. So when someone's heart rate is climbing above 120, we start to think of that the role of heart rate as being the dominant source of the increase in cardiac output. So when you're exercising somebody, if they have underlying heart issues, it's when you get into those heart rates above 120 that any increase in exercise intensity, any further demand, is going to come with a more of an increased heart rate to dominate that cardiac output. So in cardiac patients, that's where we start to see this mismatch between supply and demand, is once the heart rate gets above 120. And we'll talk about this in cardiopulm when it comes to exercise tests to determine if someone has cardiac impairment and how well they tolerate exercise. Basically, in order for the test to be valid, patients have to get their heart rates above 120 because they have to get to that place where they're really working the heart and increasing oxygen demand. So we've tackled the cardiac output as it relates to the VO2. Let's now think about what happens to our blood pressure when we exercise. And I said blood pressure, but let's go even more specific and really think about what happens to systolic and diastolic blood pressure and why. It is important to know what you expect to happen normally and to understand what drives that response, especially when you observe things that are abnormal. So I would love it if you would take a minute and really think through if you can answer this question. What information about the person's physiology do you gain from their systolic blood pressure? And what information about physiology do you gain from their diastolic blood pressure? What do those numbers represent to you? What are you learning about your patient? Take a minute, see if you can write down the answer to that, and then pop back onto the video. So let's draw this out for a minute. This is a picture I use in pathophys. Just kind of that really simplistic rendering of the cardiovascular system, and that the heart is separated from the peripheral vascular system with the aortic valve. And the heart has to generate enough pressure to open that valve, and then it kind of overshoots and pushes blood out into the periphery, and that creates, systolic blood pressure. So what are the factors that contribute to systolic blood pressure? Well, if you increase cardiac output, that can raise systolic blood pressure. So if you increase cardiac output, which means you could increase heart rate, you could increase stroke volume, can increase blood pressure, increase systolic blood pressure. Things that increase volume, would also contribute to this, that it can increase stroke volume, which would then increase cardiac output. So systolic blood pressure, the pressure that we observe when the heart is working, is really representing the output of the heart. So systolic blood pressure is giving you an indication of cardiac function, output from the heart. So that number that you put on the top is telling you about the heart. How well is the heart working? So if you are exercising somebody and systolic pressure fails to rise, that would tell you that the heart is not keeping up with the demand. It's not sufficiently raising cardiac output. So that top number tells you a lot about what's happening in the heart. So because of that, in our conversation we just had, you would expect systolic blood pressure to rise as you increase work intensity, exercise intensity. Heading to the right of the x-axis, systolic blood pressure goes up. And that's because systolic blood pressure is a measure of how hard the heart is working. As you increase exercise intensity, you have a subsequent need to increase cardiac output. As you increase cardiac output, that is registered as a rise in systolic blood pressure. What about diastolic blood pressure? What information about physiology are you getting from the diastolic blood pressure? So remember, what is happening in the cardiac cycle during diastole? If you look at, this is Wigger's diagram on your chart here, the blue line represents ventricular pressure through the different phases. So during systole, when the heart is contracting, ventricular pressure is high because we're ejecting blood, we're creating that driving pressure. What happens during systole? Ventricular pressure is almost zero. It's way down here. So diastolic blood pressure does not represent anything in the heart. The ventricle pressure is almost zero. But what we're measuring is aortic pressure or peripheral arterial pressure. And that's the red line in this figure. And you can see that during diastole, there is still a lot of pressure in our peripheral arterial system. As you know, the number that goes in the bottom of the blood pressure recording is not zero, right? 120/80 is normal at rest. Well, what's creating this 80? Why is there 80 millimeters of mercury pressure when the heart is completely at rest and pressure in the ventricle is zero? If you remember from pathophys, when the heart contracts into the aorta, it stretches the walls of the aorta, and you have all this stored energy in the walls. So during diastole, let's see if I can redraw this up here. Here's the kind of ballooned out vessel. The walls contract back in. There's a recoiling of that pressure, and that drives the pressure during diastole. The reason there's a difference in aortic pressure compared to ventricular pressure during diastole is because aortic pressure is maintained during diastole because of the size of the blood vessels. So during diastole, the number that you are recording is telling you about what's happening in the arteries. And really specifically, it's telling you about what's happening in the arteries when the heart is at rest, right? The heart is uninvolved, aortic valve is shut, and we are talking about the peripheral vascular system. So if during systole, we just pumped all this blood into our vessels, you would expect, a huge increase in volume in the same size container. You'd expect this huge increase in pressure. But that's not actually what we see, because when we are exercising, there is a massive vasodilation. We pump a bunch of volume into these tubes, but we also increase the size of the container. This graph is showing you total peripheral resistance as it relates to exercise intensity. The greater the intensity, the greater the vasodilation and the further drop in total peripheral resistance. So because of that, when we exercise, the increased volume that gets pumped into our vascular system during systole is completely offset by the drop in total peripheral resistance, which means that during exercise, we actually expect little or no change in diastolic blood pressure at all. The reason diastolic blood pressure does not change during exercise is because you have an increased volume of blood being pumped into a system at the exact same time that you're increasing the size of the vessels with vasodilation, and those two things offset each other and result in no total change. So when you are looking at the numbers of your blood pressure, your systolic blood pressure is giving you information about how well the heart is keeping up, and the diastolic blood pressure is telling you about the peripheral vascular resistance. So the increased cardiac output is offset by the drop in total peripheral resistance. So what's important to know is this relationship of total peripheral resistance during exercise is talking about dynamic exercise, dynamic aerobic exercise, when you have metabolic activity that's pumping the blood through and causing the vasodilation. But what about when someone is doing this or any resistive exercise? Not a lot of our patients look like this guy, but what's happening in this situation when we're doing a localized intense contraction as opposed to the rhythmic activity of more of an aerobic exercise? Let's first just remember what controls blood pressure. What are the factors that would be regulating this response? The first one is sympathetic nervous system, central command. Do they know they're exercising? I would say this guy does know that he is exercising. So I think he has a pretty strong sympathetic activation. Baroreceptors. Baroreceptors are actually there to help dampen the response, right? They respond to change. And then we have those mechanoreceptors and metaboreceptors, right? The pressor response, where we talked about how the local factors in the muscle kind of communicate back to the brain and let it know what's happening in the periphery. So in the muscle, in the muscle, we have these group 3 afferents. Group 3 afferents are the mechanoreceptors. They are compressed. They register force. So during resistance activity, they would have, increased firing because of the squeeze, right? Let's see, due to the mechanical force. Giving information back to the brain. I am being squeezed, definitely drive the cardiovascular response. And then we also have the group 4 afferents. Group 4 is what responds to metabolites. So what do we think is happening to the metabolites during resistive activities? Well, you kind of want to know what happens to blood flow, right? There's blood flow going through this muscle, and it's supposed to be washing out the metabolites. During a big sustained contraction, what's happening to the blood vessels? The muscle around the blood vessel is going to completely occlude the vessel. So during resistance exercises, we see a collapse of the blood vessel. The muscle squeezes around it. And that means you get decreased blood flow during the time of the contraction. If you have less blood flow going through the muscle, what's going to happen to all the metabolites that are being generated during the resistive activity? They're going to accumulate. And you're going to see a big, big, big effect of your group 4 afferents during resistive exercise. Of the two responses, heart rate and blood pressure, group 4 has a greater influence over blood pressure. Group 3 has a greater influence on heart rate. So as you decrease blood flow and you get increased activation of your group 4 afferents, we see an exaggerated increase in blood pressure, kind of generally speaking. Well, let's take this one step further and apply what's going on here to diastolic blood pressure. Diastolic blood pressure is a number that represents what's happening in the peripheral vascular system. During this activity, what is happening in the peripheral vascular system? The muscle is squeezing the blood vessels shut, right? So instead of this global vasodilation you see with dynamic aerobic exercise, during the contraction of resistance exercise, you see a huge increase in total peripheral resistance. The vessels are completely blocked. There's no blood flow going through at all. So if total peripheral resistance is going up, what do you expect to happen to diastolic blood pressure? Well, we already have a greater influence from our group 4 afferents contributing to blood pressure, and then we have a rise in total peripheral resistance. You expect an elevation in diastolic blood pressure during resistive activity. You'd expect diastolic blood pressure to go up. So what patient does this give you the greatest concern about? When you walk through the steps of kind of exactly what's going on in relationship to the work of the heart, resistive training can be dangerous in someone who has uncontrolled hypertension, especially resistive training in larger muscle groups. The larger the muscle group, the harder the contraction, the greater the drop, the greater the effect on total peripheral resistance. This can be very significant for patients with heart disease, because if you raise afterload, the heart is now working against a higher afterload. The heart has to generate a greater amount of force for the same cardiac output. We said during dynamic exercise, there's a drop in afterload because of the vasodilation. If you do large muscle group, high strength training, you'll actually raise total peripheral resistance and raise afterload. While we're talking about blood flow going through the muscles, I think it's a good place to just drop in this training intervention that's getting really popular in physical therapy, and that is blood flow restriction training. So what you see here, this guy is doing a leg press machine, and he has a cuff on his thigh that is, there's varying protocols to how high the cuff is, but many protocols call for an occlusion of venous blood flow. The goal of blood flow restriction training is to prevent the washout of all the metabolic byproducts. Basically, you maintain arterial flow and you prevent venous flow. The goal is you're trying to trap the metabolic byproducts in the muscle, and the thinking behind it is that many of the cellular clues, or cellular signals maybe is a better word, for skeletal muscle hypertrophy, the stimulation of protein synthesis, that a lot of those genes get turned on in response to the metabolic byproducts in the muscle. So by trapping them there, the goal of the intervention is to mainly stimulate hypertrophy. That is its main avenue. Although this is an area of my research, we're actually looking at blood flow restriction training as a treatment for vascular disease, especially in patients with like diabetes who have a lot of peripheral vascular disease. But most of the time now, I'm just saying that in the future you might see this applied in other populations. This was actually one of the biggest speeches at combined section meetings last year. It was in the largest auditorium. There was standing room only for people learning about blood flow restriction training, and they were talking about other ways of adapting it for pulmonary disease and vascular disease. But what a lot of the current literature is focused on is the role of blood flow restriction training in hypertrophy. Typically, they use very low loads because high loads become very painful very quickly. So we're talking like 20 to 30% of a 1 rep max. And then including blood flow to stimulate hypertrophy. Now, it's an interesting model because this is one of those times where your evidence-based practice really comes into key when you're reading about these new novel treatments. when a lot of the studies are done, they put people at 20 to 30% of a 1 rep max with blood flow occlusion, and they compare it to conventional training at the same load. So they compare it to training at 20 to 30% of a 1 rep max. And they show you get a greater hypertrophy when you occlude. But strength training at 20 to 30% of a 1 rep max isn't really sufficient to stimulate hypertrophy. So be really careful when you read these studies on what they're comparing it to. And they've repeated these studies where they compare blood flow restriction training at 20 to 30% of a 1 rep max to a normal load that you would apply in an exercise prescription, an appropriate load to stimulate hypertrophy. And then in healthy populations, they're not seeing any effect. So it maybe this is like a stylistic choice for a healthy person. Like if they prefer to do a lower load with blood flow restriction, they can get the same effect as a strength training protocol. But this doesn't really augment above and beyond in a healthy person that has any option on the table. Where this becomes huge for PTs is we have cases all the time where patients cannot do these higher loads like a 70% of a 1 rep max. They're post-surgery, their ACL is still recovering. Amputees, this is being used on a lot, where you want the hypertrophy, but you can't get the load. It's not safe because of the joint instability around it. We have this way now. This is why it's just exploding in the PT world, where you can get the hypertrophy effects with less force generation, especially around a compromised joint. So this is being employed a ton in ACL reconstructions because you can get the hypertrophic benefit of strength training without the high loads. So I am skeptical when I see like professional athletes, using this, thinking that it's augmenting their therapy in some dramatic way. It might be a little tiny bit off the top. But again, when you start talking about patients who are compromised, who have reasons that they can't be doing traditional training, this is a really, really exciting intervention. That I just wanted to put it on your radar while we're talking about kind of things that occlude flow. This is one of the novel interventions that's out there. Okay, so finally back to Joe. We screened him. He wanted to, he had some shoulder pain, but he also really wanted to lose weight. So maybe you're thinking about a warm-up for Joe or to prescribe aerobic exercise. What would be the best for him? So he did need medical clearance for his exercise. He was screened by his MD. He was cleared to begin aerobic exercise, but his MD gave a mean arterial pressure goal, a MAP goal. MAP is mean arterial pressure, and it can be a way that physicians can prescribe exercise safely or give recommendations by giving a MAP goal. So mean arterial pressure can be calculated as kind of twice the diastolic pressure plus the systolic blood pressure divided by 3. You guys might have learned this another way. Another way of writing this exact same equation is just say 2/3 diastolic blood pressure plus 1/3 systolic blood pressure. That's really messy, sorry. Systolic blood pressure. That's that. Basically, we spend more time in diastole than systole, so you can't do the average as a straight add them together, divide by 2, because we spend more time in diastole. So you double the contribution of diastolic blood pressure and take the whole thing by 3. So mean arterial pressure goal for him was 110. So he's coming for shoulder pain. Which of these 2 warm-ups would be better for him? To go on the bike or to go on the arm bike? Let's see, what is the goal of the warm-up? Why are we including a warm-up in the first place? We want time for sympathetic nervous system to get activated. We want to increase blood flow through the muscle we're going to be exercising, and we want to generate heat. So which of these 2 would be better for him if we're going to be doing shoulder exercises? If you keep in mind the physiology of the warm-up, I think the upper body ergometer would provide a greater warm-up for strength exercises in the shoulder. If it's pain-free, if you can tolerate it. But how does this upper body ergometer relate back to his mean arterial pressure goals? Is there a difference in the blood pressure response for a patient on the bike versus on the arm bike? So at the same kind of power output of these two machines, you would actually expect a higher sympathetic response to the arm bike because you're using smaller muscles. So to generate the same force, you'd actually require a greater sympathetic output. Your central command would interpret that you're working at a much higher work rate because a smaller muscle's doing the same job as what, the whole lower body could do on the bike. So in general, we see higher sympathetic activation. Sympathetic activation is definitely going to impact the heart. I would expect that to look like higher heart rates, I would anticipate, on an arm bike because of that. The other thing that's different between these two is the surface area of the body that's involved in the exercise, right? We have vasodilation only in our active muscle groups. There is a lot of surface area active in this guy on the bike. Both lower extremities, he's got some core kicked in. Even his arms are supporting his weight that might have a higher metabolic demand than at rest. Where if you look at the gentleman on the right, he is sitting in a fully supported chair. His legs are completely at rest. Really, the only area in his body that's working are his arms and shoulders. So what would you expect to happen to total peripheral resistance in upper body work compared to lower extremity or dynamic whole body activity? You would only see vasodilation right in the working muscles. So I would not expect the same dramatic drop in total peripheral resistance on an arm ergometer compared to what you would see on a bike or whole body dynamic activity. I would expect higher amounts of total peripheral resistance. What is the impact of higher total peripheral resistance on your blood pressure response? What does it impact? I would expect elevations in diastolic blood pressure when someone is doing an arm bike compared to the change in diastolic pressure in a cycle ergometer or whole body exercise. So we have Joe. He is cleared for exercise, but with a pretty tight MAP goal. His doctor does not want this mean arterial pressure getting above 110. And the arm bike would be maybe the best warm-up for his shoulder because of the effect that the warm-up could do directly on the site. But we're at risk of getting above his MAP goal. Could there be a benefit of a warm-up on a cycle ergometer for the shoulder? Sure. He's still going to have the sympathetic response. He's still going to have an increased heat that will be throughout his body because the heat generated by the active muscles gets dispersed with the blood flow going throughout. If I had to pick the perfect warm-up for the shoulder, arm ergometer is better. If arm ergometer is going to put my patient at potentially a risk for a cardiovascular related issue, you can get the same benefit. You can get a similar benefit when you use whole body dynamic activity. It's easier on the heart and still generates the heat and the sympathetic activation. All right, so let's put Joe on the elliptical or cycle ergometer and see what happens when he starts warming up. So we took his resting vitals. So if you are taking vitals on your patient and you fail to record their resting vitals, kind of what happens during exercise becomes completely irrelevant because you don't know where they started from. His he was resting 72 beats per minute resting heart rate, and his BP was 136/88. You take it again after 2 minutes, and what do we see? Heart rate has gone up from 72 to 82, kind of a steady rise in heart rate. Systolic blood pressure has increased. Is that an expected response? Absolutely. I would expect that his heart is generating a greater cardiac output and the activity of the heart is driving the systolic blood pressure. Diastolic blood pressure has stayed relatively the same or even gone down a little bit. That would again be an expected response. I would expect he's getting vasodilation throughout his dynamically active muscles, and that's offsetting any increase in cardiac output that we saw during systole. So this is a very normal, appropriate response to the warm-up. We take it again after 5 minutes. We see that heart rate has gone up even more. That seems appropriate. It's a bit of a jump, but not out of, it wouldn't raise too much of an alarm bell. And then what's happening with BP? First of all, systolic blood pressure has gone down, right? It was 152 and now it's 140. Diastolic pressure has gone up, not significantly high, but striking me as abnormal. So what do we do here? When do you say this is too abnormal and I should stop exercise? Well, the ACSM does have recommendations on when the abnormal response to exercise should cause you to stop. Whenever someone has an onset of angina or angina-like symptoms, those are all those signs of oxygen demand mismatch at the heart: chest pain, palpitations, shortness of breath. When there is a drop in systolic blood pressure with an increasing load, which is what we saw with Joe, excessive rises in BP. Systolic pressure is greater than 250, diastolic pressure is greater than 115. Signs, again, of that mismatch, signs of poor perfusion, failure of heart rate to increase with an increased workload. Heart rate should match intensity in a linear relationship unless they're on some kind of med that would interfere with that. Noticeable changes in heart rhythm, and then they describe or they show severe fatigue. Should all be reasons why you stop. The only way you can know if a lot of these are happening is if you take vitals. So vitals are vital. You need to know resting vitals to know what the change is, and you need to record vitals during the warm-up to see how they're tolerating exercise. So a little note on the recovery. Recovery means a time period immediately following a bout of exercise. Basically, recovery ends when you're back to a resting state. And depending on the duration and the intensity of the exercise that you do, your recovery could last several seconds to several hours. It's also very much dependent on the training of the subject and how well they're trained. One thing I really want you to draw attention to is here is exercise in minutes. So this person exercised for 10 minutes and then stopped. And we're looking at heart rate, stroke volume, cardiac output. We could put BP on here as it relates to these two. What happens the moment they stop? Heart rate begins to go down the moment you stop exercise. It takes a while, right, to get all the way back down to baseline. Before you're back down to 60, it takes a while. But if you only record vitals when the person is done exercising, you are not taking an exercise recording, you are taking a recording of their recovery. Heart rate, BP, starts to change immediately when the exercise stops. So I strongly encourage you, we will practice, this semester you guys will likely be practicing this mostly on your own, but we are gonna hit it home in cardiopulm. We have to be doing exercise BPs, exercise heart rates, taking vitals while they're exercising because the recovery happens almost immediately. All right. This is acute cardiovascular response, hopefully keeping it in the clinical context of the dynamic patients that we will see. And I look forward to seeing you guys in lab, and I hope you have a great day.